One.
Good morning.
Good morning.
Good morning, Jose. We
Paula,
were just, yes.
you take over.
Okay, okay, all right.
Dr. Paula Riggs is going to moderate today's session.
Okay, well, that's fabulous. So I see Allan is kind of teed up here and ready to go. So all three of our presenters today are obviously K-12 current scholars about to sort of finish up their research that you heard about on this, the YSIG about four years ago, about this time. So Dr. Andersen is an assistant professor at University of Iowa School of Medicine and board certified child adolescent psychiatrist, and he's a NIDA ACAP K-12 awardee. And the focus of his research has been on translating findings from epigenomic studies of substance use disorders focused on alcohol and smoking. The focus today is also on clinical tools for prevention of SUD-related morbidity and mortality across the lifespan using these tools. And so, Allan, we'll keep everybody's presentation to about 15 minutes since we have an hour, and then I'll leave a couple of questions, time for a couple of questions at the end of each presentation, and I'll just introduce each of you separately. So, Allan, it's all yours, and I see that you're already screen sharing, so
thank you.
Take it away.
Yeah, so everybody can see this slide, and I'm going to move on to my first slide. Still doing okay, I hope. So I want to sort of frame my talk by going back in time to about 2007 when I was a med student at Georgetown. And at that time, I was really interested in psychiatric genetics. I'd been interested in for several years. And I remember my small interest group leaders were Carlos and Michelle Patu, who are famous schizophrenia geneticists. And so in my fourth year, I wanted to come home in the summertime and do some real psychiatric genetics research. And I connected with the researcher who would become my K-12 mentor, Dr. Rob Philibert. And at that time, he was just moving from schizophrenia genetics into epigenetics. And what we did is we studied DNA methylation of a CPG island upstream of the serotonin transporter and examined how that affected mRNA levels of the serotonin transporter. So we're still very much in this candidate gene era of psychiatry where we're looking at all the major genes. We also looked at MAOA and COMT and all those genes, but trying to use epigenetics as a way to better understand the functioning of those genes and understand neurobiology. And then so after med school, I of course had to go to residency, and that took several years. And during this time at Iowa, research continued, and my mentor, Dr. Philibert, had shifted really away from psychosis to studying substance use, including smoking and alcohol primarily. And also around this time in 2012, the first epigenome-wide chips that can measure methylation across the entire genome at tens of thousands to hundred thousands of loci had come out. And so Dr. Philibert published the first epigenome-wide association study of smoking in 2012. And I'll be telling you a little bit about some of the results from those and similar studies. But what he has told me is that this really signaled a shift in his thinking away from epigenetics as a way of understanding the neurobiology of addiction and other mental disorders to sort of viewing epigenetics as a signature of exposure to substances in the environment. So all my talk will really be about that concept, more of epigenetics as an indicator of exposure and the consequences of exposure rather than a cause of addiction. And so a few years later, I had come back to Iowa to do more research with Dr. Philibert and work on the K Award. And I had a chance to work on this study here at the bottom that was examining how we can use DNA methylation signatures as biomarkers of smoking in different populations with different rates of tobacco use, cannabis use, different rates of self-report and by that time, in that 10-year period, I really completely gone away from epigenetics as, like, again, neurobiology towards using it as a biomarker in studies. And that's how far the field has come in 10 years. So in this slide, I really want to show you guys, this is a typical epigenome-wide association study of smoking. I don't know if anybody has seen any of these before, but this is basically a Manhattan plot like you would see in any GWAS of a psychiatric or other disorder. But what you'll notice on the y-axis is that the p-values are really much, much more significant. We have p equal to 10 to the negative 60th or even more significant than that. Whereas in most GWAS, you would have values somewhere between 10 to the negative 6, 10 to the negative 8. And these are for hundreds of thousands of subjects. In epigenetics, we can have really strong signals with much smaller effect sizes, particularly in smoking, because it turns out that smoking has these really dramatic effects on the epigenome. And what I've circled here are the two genes that I chose to focus on from these epigenome-wide studies of smoking for my K award. The top is a gene called AHRR, and the bottom is a gene called GPR15. And I'm going to tell you a little bit more about the first one. The first one, AHRR, we actually measure this by looking at a specific CPG, which is a DNA methylation site called CG055. And what makes this so strongly associated with smoking is the degree of change with smoking. So what I'm circling with my mouse here is the little blue dots. These are non-smokers. And so for non-smokers, methylation at this locus is very tightly regulated, with values of around 80 to 90%. So this is kind of like the biological set point, much like our hemoglobin A1C, if we don't have diabetes, would be less than 6. And you can see as people start to smoke more cigarettes per day, we have a big shift downward in methylation. And it's somewhat quantitative. We can see the best fit curve follows a bit of a linear pattern there until we get to more of a flat part. But what this is showing is that the more you smoke, the more demethylated you get at this locus. And it's a very big difference. It's very measurable using the assays that we use. So this is why this signal is so strong in epigenome-wide studies. And on the right-hand panel, this is a study by another group, but we've done similar studies. We can see that the value of methylation for this biomarker returns to normal or close to normal as you've stopped smoking for several years to decades. And this is a big study by Zeilinger and all. And we've done similar studies where we've looked at even changes over days to weeks, and we see reversion in this, measurable reversion in this biomarker when people quit smoking. Okay, so that was gene number 1, which is kind of like the top tier biomarker for smoke exposure that we have in the epigenome. Number 2, not quite as strongly associated, but it has some very interesting biology. This gene is called GPR15, which stands for G protein coupled receptor 15. And what's interesting about this is that Bauer and colleagues here demonstrated that the reason we pick up this signal in epigenome-wide studies of smoking is that we're actually measuring an increase in T cells expressing this marker GPR15. And so because these T cells expressing GPR15 have a lower methylation value, they're expressing the gene more, so methylation is lower, we pick up that proportion of increased T cells expressing GPR15 in the blood. And so then the question is, if you, in this study by Bauer and colleagues, you have about 3 to 4 times as many of these T cells. So if you're a smoker and you triple or quadruple the number of T cells that express this marker, is there any biological effect? So this is a very intriguing question. It's even more interesting because we know that independent studies have shown that this particular gene is associated with several diseases that are also smoking-associated diseases, including inflammatory bowel disease, rheumatoid arthritis, multiple sclerosis, psoriasis, bladder cancer. So this was the second focus of my K award that I wanted to investigate. And so for AIM-1, again, going along with the second gene, GPR15, I wanted to investigate whether in a cohort of African Americans who were young adults at that time in their late 20s with high rates of tobacco and cannabis smoking, do we see the increased GPR15 T cell levels being associated with signatures of inflammation? And so to accomplish this, we used our typical self-report measures. We measured methylation at all of the different biomarkers that we measure. I did flow cytometry to measure these T cells directly, and then we also did assays of serum cytokines. And so what we found is, yes, the people that smoke both tobacco and cannabis, both seem to have this effective increase in these GPR15 T cells. The epigenetic biomarkers strongly correspond to the T cell levels as we predicted. But most interestingly, we found that when you actually group together the inflammatory cytokines and the anti-inflammatory cytokines, the ratio is skewed towards the inflammatory state in the people that have high levels of GPR15 due to smoking. And in mediation analyses, we actually showed that those with higher levels of inflammatory cytokines, it was due to the GPR15 T cells, that those mediated the relationship between smoking and the inflammation. And that is in submission. It's been a little hard to get reviewers, but I'm hoping to get that published soon. For AIM-2, going back to the high-performing biomarker that I mentioned first, that first gene, AHRR, we wanted to look in a younger group of people, high schoolers in Eastern Iowa. We looked at 450 10th graders. And these were these were youth that were at high risk for smoking because they said that they had either a friend or a family member who smoked, so putting them at high risk. And what we did is we followed them at multiple time points from 10th to 12th grade. We got multiple types of tissue, blood, saliva, urine, and we measured our DNA methylation biomarkers to assess smoking. And in this study, we were interested in going one step further and saying, well, for adolescents, can we get a good signal from saliva so that we may be able to detect smoking in adolescents that are not willing to give a blood sample? And what we found is that we do have a somewhat of a good predictive value for saliva using our single epigenetic biomarker alone with an AUC of about 0.7. So not great, but better than chance. But then on the right-hand panel, when we add to our predictive algorithm a epigenetic correction factor that actually corrects for the presence of buccal cells in the saliva admixed with the white blood cells, that actually increase our predictive ability substantially to about 0.8%, 0.80 or 0.79. And we're hoping that in continuing to sort of refine and develop these saliva markers and use appropriate corrections, we may have an adequately sensitive and specific biomarker for adolescent smoking that we can do in saliva alone, which may be much more well suited to detecting smoking than, say, self-report. And so that was sort of aim 2 of my work on the K word. So things that we're working on now, going back to the T cell marker GPR15, we know that this marker, T cell marker traffics T cells to certain parts of the body, and in particular, there's a ligand for this marker called GPR15L ligand that is highly expressed in the gut, starting from the oropharynx all the way down to the colon. And if you recall, some of the disease associations were inflammatory bowel disease and that sort of thing. So what I'm doing is I'm partnering with a dentist who has expertise in the oral microbiome and the oral immune system. And what we're actually going to recruit people that use different forms of nicotine, tobacco smoking, smokeless tobacco, e-cigarettes, and actually do oral biopsies and look at both the microbiome and the immune cell composition in the mouth and see whether different forms of nicotine and tobacco use correspond to increase in GPR15 expression in the oral cavity and whether this also correlates with changes in the microbiome and potentially oral disease. And so we're sort of trying to move one step closer to smoking-associated disease and being able to use these tools to sort of predict and prevent disease. One other thing our laboratory group has been interested in, I mentioned at the beginning, we've also looked quite a bit at alcohol, and through studies of over 100 individuals that have been treated for alcohol use disorder in Eastern Iowa and also non-drinking controls, we found similar high-performing biomarkers for alcohol exposure. And what you'll notice here on the right is the top and the bottom are two sets of biomarkers. The red and pink boxes are the alcohol use disorder subjects, and the blue are the controls. And you can see that we have pretty clear separation of those box plots. The signal is not as strong as smoking, so we actually combine 2 to get better predictive value. But when we do that, we have an AUC of about 0.95 in predicting alcohol use disorder case control status. And so what we're hoping to do with these, the really interesting thing about this study is that we have biosamples that have been in liquid nitrogen since the late 90s that are part of this long-running study called the Collaborative Studies on the Genetics of Alcoholism, where people have serial assessments for alcohol use, related disorders, and also get biosamples and cognitive testing. We're going to see if epigenetic signatures of alcohol use from the late 90s, now 25 years later, predict mortality and predict cognitive decline using updated National Death Index search and cognitive testing. And that's going to be in collaboration with one of my K-12 mentors, Dr. Sam Cooperman, who is a co-PI in that study. And then lastly, what we'd like to do is to move into the
document section. I've shared.
Sorry, I'll just continue. Should I continue? Okay. So, so what we'd like to do lastly is move into treatment and basically use these saliva-based epigenetic biomarkers to monitor treatment and do that in combination with incentive-based programming using an app-based system. And what we find is that although the saliva-based biomarkers didn't perform that well in the 10th and 12th and 11th and 12th graders, when you get to adult smokers who have higher levels of nicotine dependence, higher cotinine levels, they actually perform very well in saliva. So in this study, when you correct for gender, age, and then the cellular heterogeneity. We have an AUC of about 0.98. So very good accuracy, sensitivity, specificity in predicting current use of cigarettes. And so we're hoping to just integrate that into a cutting edge treatment paradigm using apps and contingencies. That's still in development, but we're really looking to get into translating our findings into treatment, basically. And so lastly, we have some questions as we continue to cope and grapple with the impact of COVID on our research. A lot of things have really slowed down. We've been able to make some shifts to remote interviewing, and thanks to the saliva work that we've done, we feel like we have a really good chance of continuing to translate using saliva-based DNA collection. But there's an open question is whether the quality of research will be as good using all these safe, distant measures. And then continuing to think about how can we translate things specifically to young adult and adolescent populations where the impact of substance use, the cumulative exposure is going to be less, and it's harder to detect those signals. And so how do we adapt and apply our epigenetic biomarkers in young adult and adolescent populations? And so with that, I just want to thank NIDA, of course, ACAP, and then my mentors, Dr. Cooperman and Dr. Philibert, who you can see down there in the bottom right. And I'm happy to take any questions if we have a minute.
We do have a minute. Allan, that was superb. Really exciting direction. Any questions or comments from those viewing? For me, one of the most exciting things about your area of research too is this potential for being a biomarker of recovery too. We need very more accurate ways of measuring exposure and also what happens in recovery. And I just think it's a very exciting area of research. So Allan, thank you so much.
Thanks.
Thank you so much.
Stop my share.
Stop your share, and then let's see who's up next. Roya or Eraka? If you haven't decided, Eraka, you want to go? You want to tee up?
I think I was next. Okay.
Okay, perfect. Okay, while you're getting ready to screen share, I'll just do the introduction. So Eraka is Associate Professor in the Department of Psychiatry and Director of Child and Forensic Services, and Associate Chair for Equity, Diversity, and Inclusion at the Jane and Terry Simmel Institute for Neuroscience and Human Behavior at UCLA. She's board certified child, adolescent, and adult forensic psychiatry and has a longstanding interest in healthcare disparities, minority and community mental health, with particular interest in addiction and trauma in special populations of juvenile justice and foster care youth, especially, and then focused on sexually trafficked adolescents. So Eraka, thank you so much, and take it away.
Thanks. I'm having just one little difficulty. My slides are advancing just with the talking, so just bear with me 1 second. Okay. Okay. Share. Okay.
Great.
Can everyone see my screen?
There you go.
Great.
Yes.
Thank you, everyone. So I'm going to talk to you a little bit about an adaptive reproductive health curriculum for youth impacted by commercial sexual exploitation called My Body, My Choice. And first, we're going to give you an overview about commercial sexual exploitation, give you an understanding about who's at risk, walk you through some of the past studies and findings from my research, and talk a little bit about the adaptive curriculum. So commercial sexual exploitation of children really refers to inducing a minor into performing sexual acts in exchange for anything of value. So it doesn't have to be money. It can be any sort of basic needs, food, clothing, or shelter. And this is really a child welfare issue. The majority of youth who are impacted by commercial sexual exploitation do have some history of victimization and child welfare involvement. And typically these are youth who are experiencing homelessness. They are disproportionately youth of color, LGBTQ youth who run away, who are in foster care. And I think the point about thinking about these personal and social identities is that you can see that many of them are overlapping. So within the homelessness population, there are many LGBTQ youth because they're at risk for running away and being marginalized. So it's important to think about intersectionality and how that plays a role in terms of risk. And really, this population has multiple high health needs. And one of the things we found is that youth impacted by commercial sexual exploitation have really high reproductive health needs. And on some levels, that's not surprising because of the nature of the trafficking, but both prior to and during exploitation, they have both unintended and unplanned pregnancies, high rates of STIs, and these needs are often exacerbated by substance use that occurs both prior to exploitation and over the course of exploitation. Many traffickers use substances to really get the youth dependent, make them more amenable to staying in the life. And so substances become a big problem for youth. In LA County, this is just a quick snapshot of demographics, but essentially it's a disproportionately Black and brown problem. And so in terms of some of the findings as they pertain to reproductive health from the K-12 studies, I really sort of tried to maximize my ACAP NIDA funding, which I've been so grateful for. But I started back in 2015, 2016, and really wanted to understand in a mixed methods way the sort of needs of this population, particularly from the youth perspectives themselves, and how what facilitators and barriers were for them to access services. They get a bad rap, this population, in terms of being difficult to engage in care. And so I really wanted to get their perspectives from their own voices. In addition, I had the unique opportunity to partner with a specialty court that serves this population. LA County has the first and oldest sex trafficking court within its delinquency system called the Star Court. And they had no data infrastructure, so they agreed to work with me as a data partner. And so I had the unique opportunity to sort of look at their court files. And one of the things that they were interested in is understanding some of the pregnancy rates. And so what we found was that these youth have really high pregnancy rates. Over a third had been pregnant, 18% had multiple pregnancies. And one of the most stark things actually was that most of these pregnancies were actually occurring during court supervision. So the STAR Court, which stands for Succeeding Through Achievement and Resilience, is a multidisciplinary specialty court model where youth are getting wraparound services that are trauma informed. And they're really focused on intensive case management, connecting to mental health and substance use, but it was a missed opportunity in terms of thinking about their reproductive health. And so the judge and many of the different partners were really concerned, like, why are all these girls getting pregnant and what can we do better? And so what we found was that this ended up being, at the time, the largest study of pregnancy outcomes in the US of girls impacted by CSE. We also found that pregnancy was associated with parental incarceration and maternal substance use. And it's really important to really put reproductive health as providers sort of central to mental health and substance use needs for these youth, and really all justice-involved youth, just in terms of their developmental trajectories and the type of risk they have. And so we really thought having this be more centered in terms of the landscape and having this be really part of the work going forward. So one of the things that I felt was missing in some of the focus groups was really kind of getting more granular. I noticed that girls were less likely to give really detailed information. So we did some semi-structured interviews to get more specificity around some reproductive concerns. And we really found that even though they preferred condom use, it was pretty inconsistent, and that they were getting a lot of their reproductive health knowledge from peers. And so there were a lot of sort of misconceptions around reproductive health in general. And so this really sort of signaled, again, another opportunity and another need. And also the youth also highlighted other wants. So they really wanted opportunities for sexual health education. They really wanted social media outreach around reproductive health. They wanted more access to services, as well as basic needs and lower cost of supplies. And so part of when I got excited about this work was really, I was wanting to think about digital technologies and how to apply them in the justice and child welfare environment, and see if there is a way to sort of increase youth engagement to court-referred programming. And so the sort of mashup idea of seeing if this could work with youth around reproductive healthcare kind of was born, and influenced by the previous studies. And so we really wanted to gauge feasibility and acceptability of an mHealth tool from the perspectives of youth and stakeholders. And really, mHealth is an intervention that really aims to facilitate and promote healthcare services through technology, sometimes referred to digital health, but really I'm referring to use of mobile technologies using phones. The average teen sends over 3,300 texts per month. Many people think that because youth might be, who are just as involved, might be under-resourced, they don't have phones, but that's actually not true. And so I wanted to really see how these youth were engaging in technology. And really, justice-involved youth in particular, really, we need to sort of start thinking about them digitally, because when they're on probation, they have several different probationary demands, and many of those demands are not listed in an on-demand format where they can access their information. And when they don't meet those demands, they end up going back into being incarcerated. And so how can we sort of leverage technology more meaningfully in this space? So those were some of the questions that kind of drove focus groups. So we had 4 focus groups with 14 cisgender female youth identified as impacted by commercial sexual exploitation. We really wanted to get a sense of like, how are they using technology to communicate with providers and to navigate their health related services and court mandated programming. And one of the things that was really interesting was like 2/3 of them were actually regularly communicating with their probation staff, social worker, caseworkers, and they were also expressed interest in accessing information related to appointments, lab results, activities, and medication reminders. And so these sort of emergent themes, they really sort of wanted personalization, they wanted avatars, they wanted to use tech as a way to communicate with providers. They wanted to be able to really have the technology be a way to sort of increase their self-reliance and self-management. And then they also wanted, they're also amenable to not only mental health videos, but reproductive and sexual health content. So that sort of led us to the My Body, My Choice. And so this is the first adapted reproductive health curriculum specifically for youth impacted by CSE. And essentially we took an existing evidence-based curriculum called Making Proud Choices, which is for youth in out-of-home care. And we really decided to take this intervention and tweak it really for youth who are impacted by CSE. And one of the things, and I'm gonna just go to the slide, one of the reasons why we started with Making Proud Choices is that it's been found to be effective with out-of-home care youth. However, there are a lot of things missing in terms of adapting it for youth impacted by commercial sexual exploitation. So it was missing the survivor voice, it wasn't trauma informed. And so we thought that this would have good utility. Also, our community partners at Los Angeles Reproductive Health Equity Project had good sort of pilot data with child welfare youth. So our aims are to sort of adapt it with lived experience experts in a trauma-informed manner, then to test the feasibility, acceptability, determine whether it reduces sexual risk-taking behaviors and increases reproductive health knowledge and self-sufficiency at 1 and 3 months intervals. And then we're going to supplement the knowledge and skills through text messaging. And so again, the original curriculum is adapted. So the ways in which it's different is that we're using a participatory informatics approach. We're adding a substance use psychoeducation arm, making it trauma informed. And I think the really unique aspect is having it be survivor centered and led. So our version is the survivor leaders are actually co-facilitating the intervention. So currently, all good plans are canceled with COVID. So we are, we've pivoted to trying to adapt this to the virtual format. And so we've gone through phase 1, and we are in the process, well, we've completed our adaptation to the online intervention. And so we're here, and we've been actually having several, one of the, I guess, silver linings of the pandemic is really working closely with our youth advisory board and really sort of digging through the feasibility and acceptability of the virtual format. And so youth have really been working with us in sort of, participatory informatics way in terms of designing the actual text message content, to helping us tweak the types of messages that they are going to receive, giving us feedback on the actual quizzes, the sort of interface of the intervention. This is just a study timeline overview. So essentially youth will be assented. Intervention baseline. So our goal is to have 50 youth ages 13 to 18 who are child welfare involved. Youth will, between intervention baseline, they will receive 1 text and 1 retention quiz per week with a total of 8 messages. At 1 month follow-up, they'll also have post-tests, and they'll get text messages and retention quizzes. And then there'll be a 3-month follow-up. And so they'll be getting retention quizzes basically sent via text message. And in addition to the retention quizzes, they'll also be getting affirmation messages. Youth really highlighted that in addition to getting retention quizzes, they really wanted to get what they described as empowerment pop-ups. So they wanted to get encouraging messages to sort of, remind them of positive, positive things in life. This is an example of the curriculum. The curriculum is actually a multimedia curriculum that is both, has both written formats. All youth will get a sort of digital workbook, and we'll also be doing videos. And it really not only focuses on pregnancy prevention, but also teaches them about parenting. And this is an example of the substance use module we added. One of the feedback we got from youth was that they didn't really want abstinence-focused substance use messaging, but they wanted to hear about how substance use impacted judgment, and particularly around consent. So we have a module around that. And so really we focused on how marijuana can, for example, we go through different, all the different substances, but we really focused on how different drugs can impact their behaviors, particularly as it pertains to making sexual choices. So what does this have to do with consent? A lot of youth really have not thought about this, particularly as they're exiting the life. How does weed impair judgment? And then this is an example of what our retention quizzes looks like with the user interface. And so youth have also been helping us sort of pick the different types of GIFs and memes that will be populated within the text boxes. And so this is an example in terms of attitudes and beliefs around HIV. So our goal is really to launch in November. We are pending our last round of court approval. One of the things that is the challenge is figuring out with Zoom, because a lot of kids have Zoom fatigue. Normally this workshop is given over 3 days for around 5 hours, 6 hours per day. And so we may sort of shift to doing it 2 hours per day over a longer period. And that's what we're currently getting feedback from our youth. We have a lot of different partners that we're really grateful to be working with. And that's it. Thank you.
Well, thank you, Eraka. We have time for maybe one question or a comment if folks have that. I think it's fair to say, Eraka, that you are probably the expert on the planet right now in this, and have heard their voices more truly, the CSE population. So thank you for your work.
These girls are, sometimes they're homeless, or sometimes they're in foster care, sometimes they're in jail. But what's the percent of time that they may be with a family member?
So it depends, I think, on where you are geographically. At least in LA County, our judge says like around a quarter of the time they're at home. So in terms of her court involved sample, we are not like, so when we roll out our My Body, My Choice, we would be interested in working with youth who are living at home, as well as those who are in suitable placement. But obviously it'll be harder to work with kids who are unstably housed. But not impossible, right? If they have phones and are connected.
And do you know anything about the quality of the home situation, the family situation?
So, I mean, in terms of, I mean, there's traffickers come in many shapes and forms. And so sometimes family members, it's not uncommon for family members to be the traffickers themselves. That said, that doesn't mean that that's the home situation that the youth is in, but that could be or could have been at a given time. So, I mean, it's such a, and my colleague Dawn Bounds is on the phone too, and she's also a CSE expert, but it's really variable. You know, they're really heterogeneous populations. So, and there's rural, variation as well. But there's, so it really depends. But sometimes there's, sometimes they're not living with their biological parents, right? So they may be with different caregivers. So let's say if kids were trafficked by the parents, well, maybe they're living with an aunt or an older sibling or some sort of trusted adult, or the way family is defined kind of looks different.
Thank you for an excellent presentation.
And Jose, this is Rajan. If I can add to what Eraka said, a great presentation, Eraka. And this will probably be a little bit of a segue to Roya's presentation. I mean, I think one of the things that's clear is that if you can get to these young people early in their experience, so often as they're going into this homelessness phase, and you can intervene early, right? And I think Eraka's use of technology is really innovative in that you can really try to maybe leverage that. And Dawn's been working on, sort of a family reunification intervention, right? And trying to use Stride. So Norwita Milburn, who's mentoring both Eraka and Dawn, is, and I think involved with Roya's work too, there's a lot of opportunity. And so actually, fortunately on this call, we have like a whole breadth of experience and expertise here. And so this is one of those rare moments where all these projects kind of align together to provide a true continuum of care.
Thank you, guys. Thank you. I want to make sure that we have plenty of time for the next presentation. Also, thank you, Eraka. So Dr. Roya Ejadi-Maksudi is an assistant professor at UCLA and Department of Psychiatry, Biobehavioral Science, as well as an investigator at the Center for the Study of Healthcare Innovation and Implementation and Policy within the VA, Greater LA area. And so Roya's focus, she'll be describing, and her research focus has been better understanding the needs of youth and family who are experiencing homelessness and parental substance use, based on her qualitative interviews conducted with families who are experiencing homelessness and homeless services provided throughout the LA area. So she's going to be describing an innovative intervention that they have adapted. So Roya, please take it away.
Great. Thanks so much, Paula. Thanks everyone for letting me talk today, and really glad to be here with y'all. And it's always nice to hear from Allan and see University of Iowa, which is where I went to medical school, and see those friendly faces. So, and I'm pleased to follow Eraka. This is a good segue, as Niranjan brought up. So yeah, and then just disclosures, I'm really thankful for the ACAP NIDA K-12 Career Development Award. It's been an amazing opportunity to work on this research, and some other pilot awards who've helped fund the research program. So I'm here to talk about family homelessness. So, following sex trafficking, and so really is a critical issue in the United States. So families make up 1/3 of the US homeless population. The point in time count in Los Angeles showed 8,308 people in families who are homeless. The point in time counts where they go out and I've actually done it, I don't know if others have done it too, they count people who are experiencing homelessness, tends to miss families. And so we tend to use the Department of Education kind of definition and counting of homelessness, where they count children who are living doubled up, who are living in campgrounds, who are living in mobile homes. So there's 1.5 million children who are currently homeless. And most of these children are living, and youth are living doubled up. So they tend to be couch surfing or kind of living with other families. But it's a growing crisis. The numbers are increasing each year. So it's been a really a critical topic I've been really interested in addressing, especially in Los Angeles, where we've unfortunately been called like the homeless capital of the world and other things like that, or of the United States. And so reasons for family homelessness, and it's interesting, when I started this work, 5 years ago in the K, or even during my postdoc prior to that, we're seeing more and more homelessness, and it's different throughout the US. In Los Angeles, we're seeing, and I think elsewhere too, we're seeing an affordable housing crisis kind of driving this. So people just cannot afford rent and can't afford staying in their apartments. But we also see lack of housing assistance. In the study I'm going to talk about, the families we interviewed, only one of them had a housing voucher, which would secure them permanent supportive housing. The rest had no housing plan, when I was interviewing these families. Evictions, unlivable wages. Domestic and family violence is a significant cause of homelessness. So domestic violence causing homelessness, and then racist housing policies. So evictions, we see discrimination against families who are trying to use housing vouchers, who are trying to obtain apartments. We see evictions disproportionately affecting Black families who are more likely to rent their homes and then are hardest hit. And we're very concerned right now with COVID-19, increasing evictions and widening this gap as well, because the CARES Act has tend to favor homeowners rather than renters. And then just the rent being too high. So there's a lot, you can look at your state and kind of see that if there's a gap in renting affordable homes. And so generally there's only 36 affordable and available rental homes for every 100 extremely low income renter households. So we just don't have enough affordable housing. That's just a big issue for us. So, and then the population that I'm most interested in are these families who have parental substance use disorders and parental substance use. When I was doing my postdoc at the VA working with veteran families, we really found substance use in the parents was an issue, but parents weren't talking about it. It wasn't being brought up. And so that kind of spurred my interest in it. But these things really go hand in hand. So we see, mothers with significant rates of trauma. And then studies have shown that high rates of substance use in moms who are experiencing homelessness as well. And so this really puts children in these families at greater risk for problems, for developing their own substance use disorders, mental health problems, poor health, building on Eraka's talk, children in these families are at risk for out-of-home placements, but then we also see this cycle where then they're at greater risk again of homelessness later in life, and academic failures and justice involvement, thinking of Eraka's population as well. So, really needing this family-based preventive programs for families who are experiencing homelessness, because children exist in this family system. We're seeing children and youth homeless with their families who are at risk. And we know that family level preventive interventions work to prevent youth SUDs and mental health problems, but we've, even in my work clinically, we haven't, there's been a lack of evidence-based programs specifically for families that are homeless and experiencing parental SUDs. So that leads me to my study funded by the NIDA K Award, with a nice picture of the non-smoke filled Los Angeles. And really the goals of my project were to describe the unique needs of youth and family members experiencing homelessness through in-depth qualitative interviews, and then to adapt this family resilience intervention called FOCUS, Families Overcoming Under Stress, for these families, using the qualitative interviews, doing work groups with parents who had homeless experience, and then piloting our adaptive program, this 8-week intervention, and looking at the acceptability and feasibility, and then all these outcomes, youth mental health outcomes, parent mental health and substance use outcomes, family functioning, housing outcomes. And the reason we chose the FOCUS intervention, the Families Overcoming Under Stress, this is an intervention that's been used with military families with trauma. And because of the trauma experiences of our families experiencing homelessness, we chose to adapt it. And the core FOCUS intervention, it really is simple CBT skills, like helping families to develop a shared experience through a narrative timeline of their experiencing, teaching these 5 resilience skills: emotion regulation, problem solving, communication, goal setting, and managing reminders, and has been shown to improve communication, coping in these really distressed families with trauma. But a lot of these skills that they teach also can prevent substance use problems and mental health problems in youth, like teaching goal setting, communication, parent modeling. And I wanted to share with you today our findings from our qualitative interview. So we interviewed 56 participants throughout Los Angeles County. We interviewed parents experiencing homelessness who had a history of a substance use disorder within the past 2 years, youth between the ages of 10 to 18, so kids of these parents. And then we interviewed 25 homeless service providers throughout LA. And we were initially going to interview less, but there was a lot of the homeless service providers really wanted to talk. They really wanted to tell us about their experiences with this population. And we did demographic questionnaires, and then we did semi-structured interviews, transcribed them, and then we analyzed them using content analysis. And we mapped our interview guides on also to the intervention that we were interested in adapting. So we asked about family experiences, shared experiences. We asked them about the kids, the parents, the providers, about these different family processes and resilience skills. We asked about coping, including substance use, strengths, and then barriers with services and recommendations for families, kind of structurally, and then also for intervention, providing interventions. So for our parents, the average age was about 40 years old. And we had mostly racial ethnic minorities. And the median length of the current homelessness episode was about 12 months, although families will tend to kind of fall in and out of homelessness. This was the population we were working with. And we recruited these families from transitional housing in Los Angeles. And that's why these are families who are not permanently housed, and they're expected to get permanent housing after this step. We have so this is a very high risk group. So our key findings, I just wanted to share some of our findings from our parents. There's a lot of information, and some from our kids. From the parents, trauma being pervasive throughout their lives. This notion of guilt permeating all parenting. So just guilt over past substance use and trauma kind of interfering with moving forward with parenting. This communication breakdown. So families had trouble talking about the past, homelessness, substance use. And we asked parents about talking about substance use with their kids. And we found this theme that it can be hard. So parents did talk to their children, but they felt afraid, they felt guilty, they felt embarrassed. One parent called it the dark elephant in the room, thinking of her own history and what her kids had witnessed and not being able to talk to them about it. And they wanted support. Talking with them. And then households are in a pernicious environment. So I think we can't really do this work without thinking about the struggles these families are facing in the environment. So just not having housing, housing in unsafe areas, discrimination, people feeling, racially discriminated against when they were trying to seek housing. So I'm interviewing these families who, could have returned to the streets. They didn't really have plans of where to go after the housing. And then parents needing more support. So one parent said they just want to see us fail. So just kind of feeling like they weren't being bolstered to success. So, and just touching on this theme of trauma. So one mom said, my first son passed away. I was very young. I was 15. He passed away at 6 months, and I never got help for that. I never got therapy. I didn't process it. I was a mess. That's when I started smoking weed. And then after that, it was the meth for about a year. So just this, really stressful situations, and then substance use kind of starting after that, and young. A lot of these parents had trauma when they were pretty young. And then this theme of guilt permeating all parenting. And this is kind of a classic kind of example. This mom said, I regret letting all that time go by, and my addiction and my homelessness. I would have gotten my kids back, my housing back, and rid of the addiction, but I didn't. It took me 9 years to do it. So just, thinking of their past and like these years that had been lost was pretty profound among a lot of the moms. And we did publish this paper and the findings with these parents. If you're interested, this is the publication. And from the youth, so we also interviewed youth, and we found similar themes, homelessness as a trauma, but some difference, which I'll get into. And then the transitional housing being hard. So youth, and this didn't really come up with the parents, but the youth were really scared of getting kicked out, and they were scared of getting their parents kicked out. They were worried about the rules. They couldn't bring friends over. The stress of homelessness seeping into school. So kids struggle to do homework. And then we have to help our youth are focused on finding housing and finding jobs. And then this theme of homelessness as a trauma for kids, really the trauma of family separation, and then also the trauma of the environment. So they witnessed things. They saw, people selling drugs outside their facility. They saw kind of dangerous things outside. And so it was a different trauma than what parents described. And then this theme of we have to help her. So, this constant belief that they have to help their mom get a job. We asked them about their own goals, and they couldn't tell us about their own goals, but they had, they wanted to help get a house, get a job. And so we used all these findings to adapt this intervention. And, some of the core components of the intervention, communication, we added an earlier session focused on communication and active listening, because we felt that communication had been such a barrier for the families. This goal setting, we couldn't ignore the case management kind of structural goals. So we added kind of a goal about that, but we also added a session on helping youth with their own goals and stating their own youth goals and life plans, because that was so stark that the kids weren't able to express that. And then a session on substance use disorder prevention and talking to kids about this. And this is just a kind of a brief example of a skill. This is a coming to terms skill working with parents, and that's helping parents communicate to their children about their mental health, their substance use, preparing for a discussion. So with this acronym terms, talking with children about illness or problems in words they can understand, explain how changes impact the family, reassure children by addressing safety, fear, and concerns, monitor reactions, share feelings, and encourage children to do so with adults. So helping them kind of prepare for these discussions kind of with their kids. And so our third aim is pilot testing. So recruiting, we're doing baseline surveys and randomizing families to the intervention versus treatment as usual, doing a 3-month survey and a 6-month survey. Like Eraka, COVID hit March. LA, shut down the week of March, the third week in March, right when we were recruiting all these families, and we had to not be in the facilities as a risk. So we have converted everything to tele. We have iPads that we've finally got IRB approval for that we're delivering to families instead of having to rely on the families like one Chromebook. So that's where we are now, and just rapidly increasing our recruitment sites, doing surveys at baseline, 3 months and 6 months follow-ups. And our primary outcome is feasibility and acceptability. And then these secondary outcomes as well. So, and I just some general recommendations from all this for anyone working clinically with these families. The main takeaways we found is that parents and youth may not disclose they're homeless. Parents may be afraid to disclose substance use. It's really essential that we provide treatment and support for the mothers, and then take the view of the child regarding the stressors. The kids have different stressors than the parents and see things differently. And I just wanted to thank all the team members and collaborators. So we've been partnered with several housing facilities. And this is just a quote from a kid when we asked them what they should tell families moving forward. He said, keep your head up and just always stay positive. You'll get the help that you need. You'll end up being settled sooner or later. You're not going to stay in one place forever. You're just going to keep on moving. So I know we're almost out of time, so I'm trying to share a lot.
Wow. Thank you for working with this population and educating all of us. The communication issues are really striking, aren't they? That they really want help with the communication. Comments, questions for Roy? We have a couple of minutes.
Maria, I noticed like in the transition housing, I was surprised that there was such a high amount of Caucasian families. And did you think that that was surprising? Because it was like 38%, and I guess I thought it would be, do they have more access because it's true, because it's not on the street? I guess I thought the demographics would be different.
Yeah, I mean,
it's still time from the faculty here, but.
Right. So yeah, I mean, I think, so what we see in LA is a lot of times like Latino families will be more doubled up. And I was in the housing facility. So I wasn't going to, I wasn't on the streets. I wasn't in, so I think maybe I was getting kind of a different sample, people who were accessing resources differently. And it might've just been the nature, of where we were too. And in Los Angeles as well, some of the facilities in terms of the breakdown. But I mean, in Los Angeles, we see overrepresentation of Black people experiencing homelessness. But I did have a higher kind of Caucasian sample. So
it was like 38.
Right. Yeah. So it may have been that, where we were, we were in these transitional housing. We weren't elsewhere. Right. So we're kind of getting this sample of people who are getting the services. So exactly as you pointed out. But the thing that was distressing is transitional housing ends, and then you have to have a plan next. You have to go into rapid rehousing or permanent supportive housing, and that's where a lot of these families were stuck. Yeah.
Well, thank you all of you. Impressive work. I thank you so much. The field is in great hands, and you're moving the field forward in very important ways. So, and thank everybody for being here today and hearing the kind of more of the final results of where they started 4 or 5 years ago. So thank you so much, everyone. And be well, be safe.
Thanks.
Thank you so much. Bye-bye.
Bye.
Bye.